So my name is Greg Elder, and I am currently leading the MedOps task force on the changing humanitarian landscape. And we're going to do a survey. I don't have a clever QR code because I don't know how that works. So no Mentimeter, but I want everyone who is currently responsible for a project, working on a project in the field, managing projects, to stand up. This wakes you up a little bit for the last session. So stand up, everyone who's working on a project in the field or is managing a project in the field. I would imagine nearly everyone should be standing up. So if you're working in the field on a project, if you're managing a project, if you're a referent for a project in the field, okay, that's good. That's what I expected. So around 90%. My colleagues from Luxor wouldn't like my methodology, but, well, no, don't, sit down, stand up. So keep standing. Kirsten, stand up. I saw you. So if you have not been affected, or your colleagues or your program has not been affected by the funding cuts and the policy shifts since the beginning of the year, I want you to sit down. Wow. Okay, that's a good sense check. Sorry for the people online, you couldn't participate. Nearly 100% of people who stood up, who are working on a project, their projects have been affected by the changes that are happening this year. Thank you. You can sit down. So, given the current flux marked by funding withdrawals, you still hear me okay? Marked by funding withdrawals and policy shifts in the humanitarian and global health aid, I was asked to provide a short 10-15 minutes scene setter for the final session of the day. I'm going to concentrate on 4 points. Placing the humanitarian cuts within a broader political climate, their impact on child survival, the complex roles MSF can play in this context, and whether any opportunities may emerge from the changes ahead. Number one, it's not just about the money. Shortly after taking office, President Trump signed an executive order freezing all foreign aid for 90 days. He then downsized USAID from 10,000 staff to 300, cancelled 83% of all programs and began restructuring US aid architecture under the State Department, guided by an explicit agenda to make the US safer, stronger, and more prosperous. In effect, the US dismantled its multi-billion dollar aid program. And while financial year 2026 details remain uncertain, global health and humanitarian aid budgets are expected to be cut by half, with additional dramatic cuts of between 20 and 60% reductions for all UN agencies, NGOs, and significant cuts to multilateral actors such as Gavi and the Global Fund. Other high-income country donors have also significantly reduced their funding aid commitments in recent years, preceding those of the US. Although the aid system has long suffered from inefficiencies and structural flaws, the current cuts are less about reform and more a symptom of aid being repurposed to serve donor security and diplomatic objectives. Aid is no longer driven by unmet need or saving lives. It is increasingly about preventing diseases from crossing borders and advancing a global health security agenda within an assertive, post-liberal, nationalist, geopolitical moment. Multilateralism is out. Transactional, interest-driven bilateralism is in. 2 months ago, the US State Department released the America First Global Health Strategy. It's a 50-page document that diagnoses the systemic weaknesses and proposes a radical solution. Abandon multilateralism and most civil society partnerships. Negotiate bilateral agreements conditioned on expanded roles for the private and faith-based actors. Preferential use of US manufactured goods, and compliance with conservative policy requirements, including anti-abortion clauses. Implementation is scheduled for Q2 2026. Preventative services, community engagement, health system strengthening, and program management support are explicitly deprioritized. Earlier this year, a colleague of mine interviewed senior health officials in several aid-dependent low-income countries about the coming cuts. Many diplomatically expressed that it might encourage health sovereignty and reduced dependence. But given the short timelines, none could articulate how domestic resources could be mobilized quickly enough, nor how integrating or localizing services could achieve the efficiencies needed to cover deep and immediate funding gaps. This raises a critical question for MSF. How will sans frontierism function in an explicitly nationalist political climate? 2. Stalling child survival, a dual crisis. Global humanitarian and health assistance has produced extraordinary improvements in child survival. Since 1990, under 5 mortality has fallen by 60%, driven by investments in addressing the key killers: malnutrition, vaccine-preventable diseases, pneumonia, diarrhea, malaria, TB, and HIV. The child survival revolution has been profoundly successful, at least in stable contexts. However, progress has slowed due to the polycrisis of conflict, climate change, COVID-19's aftershocks, economic contraction, and now retreat from political commitments to aid. Even before recent cuts, only 12% of ODA targeted children. The primary disease drivers continue to kill millions. 1 in 4 children experience extreme food poverty, and as we heard yesterday, 1 in 5 live in conflict settings where healthcare is even more precarious. The new wave of bilateral reductions and cuts to by multilateral agencies will directly translate into fewer children receiving life-saving immunization, increased malnutrition due to suspended feeding programs and supply ruptures of therapeutic foods, shortages of essential medicines for common childhood illnesses, and decreased maternal care with severe implications for newborn survival. Both vertical diseases-focused programs and the horizontal systems that support them are being dismantled. Preventative activities are deprioritized. This creates a dual crisis, collapsing programs and weakened systems. Children, along with the populations in fragile humanitarian contexts, are disproportionately affected. Local authorities are being told to assume responsibility, finance system-wide transformations domestically, something simply impossible within the timeframes imposed. For all actors, including MSF, the challenge is twofold: how to respond to the acute crisis and immediate gaps, and, in parallel, to support longer-term health system transformations, preparing for a new era in global health diplomacy and assistance. MSF, an emergency humanitarian actor or a global health actor, or both? I'll let you think about that for a minute. We are witnessing both a humanitarian reset and a redesign of global health architecture, finance, governance, and diplomacy. Humanitarian action is grounded in moral imperatives and supported by multilateral institutions, foreign assistance, and shared norms. It has rested on operational principles aligned with international humanitarian law. Global health, shaped by the colonial legacies of tropical medicine and hygiene, developed further through technical assistance and support from multilateral agencies, is anchored in public health ethics and in the international health regulations. As multilateralism weakens, so too do these rules and principles. Community networks and civil society organizations, crucial partners for MSF, have been early casualties of the cuts. MSF operates at the intersection of the global health of these global health domains. Our identity spans emergency response, medical expertise, independent advocacy, and principled humanitarian action. The current policy shifts heighten long-standing tensions within these multiple identities, and key questions emerge. How will MSF reconcile its dual roles as an impartial emergency humanitarian actor and as an independent global health actor over the short, medium, and long term? What guidance can we give our teams facing moral dilemmas in the field? When every collapsed vertical program becomes a new humanitarian emergency, teams must decide whether and how to cover gaps, recognizing we have finite and limited capacities. And how should we position ourselves for the future landscape? We must anticipate new actors with different aims, bilateral agreements tied to inequitable or ideologically driven health policies, shifting power dynamics, and new hierarchies of access and quality. These will pose serious questions about ethics, impartiality, security, and operational space. And finally, for those of you old enough to remember Monty Python, you'll recognize the irony in this section title. But despite the seriousness of the current moment, opportunities do exist. The humanitarian reset, WHO and UN reform processes, and prioritization exercises across global health and humanitarian agencies all champion localization and strengthened country ownership. There is genuine potential for meaningful system reform, country-led prioritization, integrated and efficient service delivery, and locally adapted health systems. But these opportunities carry risks. If poorly designed or rushed, they create new forms of dependency or push countries deeper into debt traps. Large-scale transitions in such short time frames seldom go smoothly. Between the familiar world of vertical aid programs and the envisioned integrated systems lies a steep, vertiginous transition. Shifting from one system to another requires time, expertise, additional short-term investment, not less. We should anticipate setbacks, reversals of progress, and human costs, much of which will go unmeasured and unseen, and, as often happens, children and women and poor and the different and the excluded will bear a disproportionate burden. Which brings us back to a central existential question: what role should MSF play in this evolving humanitarian and global health landscape? How will we choose to navigate this moment, balancing our core emergency response to immediate needs with a long-term vision, operational pragmatism, and principled independence? Thank you.